Who should be involved in hypertension management? Is it you? Or is it you? Who should be involved? Could be the doctor, and that could be involved, the nurses, the pharmacist. Now, I did want to find cartoons for everybody, but sometimes it's harder. So kinesiologist, Simon Bacon, please forgive me if I didn't find the right one. That's even worse, but that's for psychologists. But you should see what you find when you do nurses. It's worse. Nutritionist. So there's many people that can be involved in hypertension management. But today I will also have a guest, a mystery guest. I dressed him for Halloween. I thought it was fit, so there's this guest that I will speak about that can also be involved in hypertension management. But we're not here today to talk about the whole team. We're here today because I'm setting the stage now, because we're here to fight. Okay? We're here to decide who should be involved, and our contenders are the nurses, the pharmacists, and the doctors. So today, oh, and yes, there's my mystery guest that will also want to address a few words to you. So, how are we doing? You've heard this before, so I'm not going to spend a lot of time on this, but so far we've been doing really pretty good, because if we look back in 1992, we had 13% control, and if we look now, the latest data, we are 68%. So really, if I'd be doing this talk in Europe right now, what I'd be saying is we are the best. We have one of the best control rate. But I'm a nurse, and I work in primary care as well. So I see this number, and I'm very happy about it. And I think you guys have done a great job, achieving these numbers with the patients. But I think I'm also saddened by the fact that there's still one out of 3 patients that is still not controlled. So we still have work to do. So we still have a job. So today, what I will try to do, because I do have to, to make sure that I represent the nurses here. I will speak about the nursing role in hypertension, and of course I will bring out the results from systematic reviews and meta-analysis on the involvement of nurses in hypertension management, and I will also have a brief discussion, and if time permits, I will also invite my guest to speak to you a little bit. Okay. Nursing role. Actually, there's a very traditional role, and we still find it in some areas, where we take vital signs, we do data collection, blood samples, appointments. So this is one way to go, and it's still, I could say it's in the past, it's in the history, but actually no, it still happens, and I don't think it's the best way, but it is one way to work with nurses and as nurses. But there's a more actual role for nurses, and there's also lots of things that I'm going to talk about that can be in the future. So when I talk about the role is, don't forget that we can be involved in health assessments. So nurses that are here today, I spoke to many of them, are already really involved and engaged in this, but I just want to also alert my colleagues, doctors and pharmacists, that this is something we have to think about. They can participate in the evaluation of the patient, in screening for hypertension. We do not need a prescription to do an ABPM. We do need a doctor to read the results and diagnose, but we can order it, at least in Quebec. Engage the patient and the family in hypertension management. Help teach and evaluate lifestyle changes. Same thing for pharmacological treatment. Keep abreast of therapeutic intent. We can be involved in protocol, algorithm, collective prescription that's in Quebec. So there are many ways, many different ways in which we can be involved. What do we know about it from the literature? Well, if we look at one of the first meta-analysis that was done, it was done by a group from England, Lyne, and the aim of their meta-analysis was to determine the effectiveness of interventions to improve blood pressure control. So they got 72 studies, and the targeted intervention were really quite wide, from self-management to alert system integrated into the files. And the outcomes that were assessed are around blood pressure results. So when we look at it, the first result we have to be mindful of is there was a lot of heterogeneity, so it was impossible to aggregate. But if we look at the results, it said by subgroup, it said that organized systems were pretty good, bringing down the blood pressure, self-management. So it was the beginning. So it was published in 2010. Educational intervention, at that point, it showed unlikely to be associated. That was 2010. Nurses and pharmacists, promising, but they didn't have what they wanted. Appointment reminder system, further evaluation. So really globally, they said effective management of hypertension requires a community, systematic, and organized approach. That was back in 2010. So at the same time, Christopher Clark in England published a systematic review with nurses. So here we are. We have the result for nurses. So what did they look at? They look at nurses or nurse practitioners being involved into improving blood pressure control. 31 studies were identified, and population adults with hypertension. And again, it was not possible to combine all the studies due to heterogeneity one more time. But if we look at the results by subgroup, step treatment algorithm, we have a decrease of blood pressure, nurse prescribing, telephone monitoring, community monitoring. So really their conclusion was, although it was not possible to aggregate, it did show that it was possible to bring down the blood pressure. But those two groups got together and decided that, there were more and more studies coming in, so they decided to do 4 different meta-analyses. And one of the meta-analysis was to look at health professional-led, including nursing and pharmacists, but I didn't want to add this now, but it's nurses and pharmacists, intervention to use to improve control. I was at the meeting when they made the first announcement. I had just finished my thesis. So I raised my hand. I always want to ask questions, even if I didn't speak English so much at that time. So I raised my hand and I said, who are the nurses that are working with you to do the analysis, for the nursing interventions? And they had the whole group there, and they says, you want to take part? And so I said yes. So I took part in the Cochrane analysis. We're going to publish at the end of December this year, the latest January 2018. I also have a student, a PhD student that's involved. So we did look at RCTs of intervention, comparing hypertension care delivered by nurses, nurse prescriber, pharmacists, compared to usual care. So those are results for Dr. Bell. So types of participants were the patient that had hypertension again. The outcomes we looked at are mean systolic and diastolic blood pressure. Data source, no surprise there. We analyzed a lot, as usual, a lot of papers. Came out with 118 that were actually included. I just want to point out, because this is something that we will discuss much further in our papers, that it was most of them were pragmatic trials, and blinding of patients was pretty difficult. So I'm outlining it here. But for the sake of time, I won't discuss it much more. Now the results for nurses. Russ, I wanted to be nice, so I didn't bring the results for pharmacists, but I do have them in my slides later, but I will just show the nurses for now. So 41 studies. So those were all studies that are pretty recent. And what do we find here? And so we look on the left, it favors intervention, and on the right, it would favor usual care, so doctor care alone. And what we find is that the results show that there's a decrease in blood pressure with nurses. 15,000 participants in those studies, 41 studies. So I think this makes it pretty clear that it works. I'm sorry, I'm having trouble with the pointer. Okay. So conclusion for the meta-analysis, evidence for low systolic and diastolic outcome blood pressure with nurses-led intervention is the main result from our meta-analysis. There'll be more to discuss later on. So I could stop my talk right here and tell you that it works. There's 41 recent studies, RCTs, that are showing that. But if you did look further down my slides, and our conclusion is that it was not homogeneous. The type of interventions that nurses can do, it's actually our strength. We individualize things. We listen to the patient. We want to make it, you know, we want to customize the care for our patients. So very often, even if it's an RCT, there's a lot of individualization that goes into the trial. But it does work. So that was a very important conclusion. So I'm saying nurses must be involved in hypertension management, and that's an important issue. Now, my guess. Before I go into this further, my mystery guess is actually the people that were in the middle of my first, when I presented you the hypertension management. It's the patients. They want to say something to us. A lot of the information that we get are from RCTs, well-done RCTs with strong methodology. But sometimes we forget, and you in primary care know that much better than us that do the research, is that the patient have a voice. They have something to tell us. And as a nurse scientist, I have a different perspective, I think, because I do want to get their voice into the research projects. So that's what we did. We did the phenomenology studies. So those are studies that are with very small numbers of patients. So here was 24 men. And the phenomenology, it allows us to just listen to the patient. It's semi-structured interviews, and we basically just ask them, what is it to live with hypertension? What does it mean to you? And you know, those studies are really, when we present the results, we can't present the results with one number and aggregate what they're saying. I'm just telling you some of the message that the men are telling us. And I'm not saying that we could generalize things to all men. I'm just saying that it's important to do it. So what you are hearing in primary care, we find it in research as well. The men don't think it's really a disease. They see it as a fatality. They see it as something that's, you know, can be trivialized, or it's related to aging. They have very high expectation regarding non-pharmacological treatment. They have a fear of erectile dysfunction. We had no questions on this. There was no specific questions on side effects or anything. This came up in almost half our interviews, just solely by asking, what is it living with hypertension? And their fear of erectile dysfunction was an important issue. We have to listen to that. Facilitator for them was good relationship with health professionals, and I think that's one message that's very important. We also wanted to hear the voices of women, so we did the same thing, and it's a part of the study. So that work has been done with, and I want to say it to Anne-Marie Leclerc, who's a graduate student. So again, the same type of interviews, and women will say that it triggers, diagnosis of hypertension will trigger a sense of wanting to take a better care of themselves. So it's a time to engage them because they want to take a better care of themselves. They want to be involved. They want to measure their BP. They talk a lot about self-titrating. And I'm not comparing men to women. I'm just saying what we heard mostly from them. And facilitator, what was important for the women was emotional support from spouse and emotional support, and it was mentioned like that, emotional support from health professionals. So they expect specific things. So there's some of my colleagues in England, Richard McManus, with a student that looked at a meta-analysis, an individual patient data meta-analysis, to look at the effect of self-monitoring. So another way to engage patient is definitely self-monitoring. of blood pressure. So we had high hopes when they started that meta-analysis, and, it does look at, it favors intervention, but yet it crosses the line, so it's not non-significant. So self-monitoring alone does not seem to lower BP. But of course, as we always do with meta-analysis, we did further analysis, and what did we find is we found that if you added more, if you added feedback, if you added feedback plus education, if you added counseling, telecounseling, well, then you would find the results that were actually statistically significant. So really the conclusion was that self-monitoring can be recommended to lower BP when combined with another type of intervention. So again, it's always talking about not the patient alone or us alone, but really engaging together. So this is, I think, an important message that I want to send to you. The last one is about perceived involvement and preference in shared decision-making among patients with hypertension. That's another study that I think it's important to listen to. So they try to determine hypertensive patient perceived involvement. So what do they feel? So of course, I'm retaining only a few of the results here. So when they were asked, like, my doctor made clear a decision needs to be made, 90% agree. So they're telling us that they understand that their doctor thought a decision when it's needed. When they were asked, did the doctor help me understand all the information, 50% agree. My doctor wanted to know if I wanted to be involved, it goes down to 29%. My doctor and I selected a treatment option together, 9%, so it goes down. Although I wanted to bring it more as because we were doing it as a little bit of a debate, I want to say that if we're not careful, if the nurses and the pharmacists get involved in the same way doctors used to be involved, we could end up with exactly the same thing. Instead of saying the doctor, it could be the nurses. So it's more of the way we are involved than being a doctor or being a nurse or being a pharmacist. It's the way we engage with them. So I could tell you one thing is that from that study, patients want to be involved. So when you look at, do they want to be involved in the selecting of medication, weight reduction, they want to get involved. So you have very high numbers there. I just, and I'm almost finished, I looked at, in the Medline database, meta-analysis and hypertension. I just wanted to know what was going to come out in general. And, shared care, social support, digital interventions are really what's, what our people are talking about when we look at the studies. But look underneath, there's a whole lot of studies that are talking about other type of intervention that we have to think about that are coming in. This was written back in 2010 in French in a Société Québécoise d'Hypertension Artérielle book that was distributed through our website, but it was also translated with Hypertension Canada, and we defined the role of patient and family within the group of experts. Not only there to be taken care of, but really to sit down at the table with us and to really take ownership of the hypertension diagnosis, learn about and participate. So it was already there. It's been there. I think we are getting in a position where we can definitely do this, not only as nurses, but as pharmacists and as doctors. So there are many ways in which patient and family can be involved in hypertension management. So my conclusion would be to say that, yes, doctors, nurses, pharmacists, kinesiologists, psychologists, nutritionists, and I decided to change the way things are, and I think that's really what you are engaging in, is having the patient and their family sitting around the table, around hypertension management, instead of them receiving our messages. So really, that was my main message, take-home message. Merci beaucoup.